on to the next speaker for today. Um, the next speaker is Dr. Jayesh Trivedi. He comes from Ahmedabad now. He comes from Ahmedabad. He's currently the lab director and consultant of quality at STEM Site India Apollo Clinic. He studied at the Rural Medical College and is associate director at Dr. Reddy's laboratory in improving quality testing and care from baseline.
I'll introduce myself.
So, thank you.
Yeah, I'm coming from Ahmedabad and good afternoon all. HOD to Zydus Hospital and works for small National Accreditation Board of Lab and NABH in Transfusion Medicine. Unfortunately, Dr. Anurag Bansal could not make it for this presentation and the burden is given to me by the organizers. So let's and try and keep the pace for it. The mood is quite set actually by the previous speaker, which had about insight on management and insight on how to do a finance. So the topic becomes easier for me to take it on from here. It's just a start where, this is if we plot on X quantity and Y on quality or vice versa. Now this is where most of us are here at the current. So we are actually having less number of samples in an isolated labs and gradually our target is to move on to the high quantity and high quality. So when we become at that level, we need better and better statistics and better managemental tools to support our vision and support our patient care. So that's how our presentation would focus on Six Sigma quality management and total allowable error estimation with the application into the clinical lab. So what happens normally, people in the labs are sitting in the microscope and there are clinical atmospheres, samples coming from all over places. They do take care of patients. They accept certain times the lab results. They reject certain times. They don't feel that that's not meeting their requirements or medical data. So that's how every lab, I'm sure, every lab will go through this cycle. So what we intend to do is that there are many management tools world over. These are not just for clinical lab, not just for healthcare. There are different industries, different people are actually into this. And we are trying to apply those principles to our clinical laboratories. So Six Sigma is a concept, a business management strategy started way back in 1981, focuses on process improvement. So it's a comprehensive philosophy on operation excellence. And there are certain tools which they try and statistically use them to reduce the variation. Simple examples are, there's a car manufacturing, like Motorola started. There are mobiles manufacturing. There are manufacturing units which growingly, GE is now one of the largest applicant for the Six Sigma management. And these people focuses on reducing the variation of their product. That's endpoint. And our endpoints are actually a A4 size test results, which actually turns into the patient care. So it's a strategy where, whatever process deviations are there, you try and correct them. So it's just to give the examples, is 6 metrics performance is 3.4 defect per 10 lakhs event. That's 3.4. We come back to them. later on. So what does actually in healthcare needs today? If you look at today's market, what it needs is that they don't need errors. They need to reduce errors as much as possible. They need accuracy at all times and every time. Any labs which is working on 24 by 7, 365 days, and we are supposed to report correctly on time and every time. So, and we have to meet the demands, if it is OPD, if it is IPD, if it is home collections, there are many demands and it keeps growing. So it doesn't stay as a single static process. There is a competition across all of us. We would go and come back with our technologies and would be a competitive pricing. So end of the day, you need to be better informed and ultimately it should result into the patient care. That's why Sigma is getting a lot of importance these days. Way back in 2000, there was a paper which was produced by Nevalem, and it says that no, most of our process not even meets to the basic requirements. Now that is a paper from actually an European standard. So forget about our country. But most of our processes does not even meet 3 matrix performance. Anything which we'll come back to later slides, where anything less than 3 becomes a process is defective, and that requires correction. So another paper, first paper actually on laboratory. So what does Sigma do? So Sigma, there is definitely any Sigma is a stats, so which means there is a target and there are process capabilities. So on left hand side and right hand side, we all know standard deviations, so we move on from there to matrix performance. So 6 on this side and 6 on that side, so that becomes a target tolerance specification. Any of the technology items, and they need tolerance specifications. So every product will go through there. However, Sigma understands the shift because day-to-day variations are likely to occur. So if 1.5s shift is always taken into account. It's a universal measure of quality these days. When you start picking up your instruments, you go to caps.org or you go to westgard.com. The matrix performance of LH750 or dry chemistry, the previous speaker was telling about whether fusion or whether there are, at what matrix are they performing. So that is very critical. So at that Sigma matrix is a universal applicant. So something like CV when we say, so that is universally applicant. So irrespective of your any quantitative analytes can be converted into Sigma scaling. Sigma doesn't assume that we live in an ideal world. So there would be a process defect, there would be a time. So the businesses are such that there would be a time to take that improvement and do that. A very basic Sigma awareness is about 0 to 6 is a matrix performance. Anything less than 3 is unacceptable performance for that particular process. And most of our processes works between 3 to 5. 6 or more becomes an world-class quality performance for that particular process. Now, we are not a factory because traditionally these applications are done for the factories where there are inputs are very, they are very static. In our case, inputs are different. Patient history, data, different requirements keeps changing. So the output may not be exactly same. Even though it is an A4 size paper on the test result, it would be that way, but still there would be a difference. Sigma can be applied to the clinical labs in pre-analytical, analytical, and post-analytical processes. So that's a normal cycle where there is an MDs or a general practitioners or somebody orders a test and it gets it to the collection to transport to testing, different sections test it. So there is an analytical phase and then there is a submission either through mail, either through couriers and hard copies, and then it gets back to the diagnosis, prognosis, and treatment. So that's a normal lab cycle. Pre and post analytical area we'll cover first. So where you identify what has been traditionally done in people who are getting into the accreditation, they know about quality indicators. So you identify certain problem area of pre-analysis where you can identify, for example, how many orders are accurate, how many orders are, how many samples are accepted. So those could be your indicators, and you try and find out errors out of them. So the job becomes exactly reverse, that whatever is being said, you try and find out something, errors out of them, document them, and these errors are counted. Now when we count it in 100, it becomes percentage. And when we count it in defect per million opportunity, that gets converted into sigma matrix. This is a very simple website where you can do that calculation on Westguard, where you just put your error rate and it would give you the matrix performance. Suppose, to give you a fair idea, now if you have a 3 sample rejected out of, let's say 100, it is actually, that should be a 0.3, and then rejection of, when we count it in 1000, the matrix becomes, and if it is 0.3, then it becomes 4.3 matrix. If it is 0.03, in terms of percentage, it becomes 5 matrix performance. And only when it is 0.034, it becomes 6 matrix performance. So if we count our processes, I've just put them on, there is a body called as IQLM, International Quality in Lab Medicine, where they put it certain indicators, for example, order accuracy, duplicate test orders, that happens at reception area. Wristband errors happens at the most of the hospitals where identifications are there. You look at TDM timing errors, that's international, and that is at 2.2 matrix. So TDM is toxic drug metabolites testing, where the right timing is very important, critical for analysis. Now, if you do not achieve that, now that's very important, that TDM timing errors are 2.2 at international level. So we have to, there are no stats available with us. Normally what happens is that in Western world, quality indicators are tracked as QTrack and QProbe, and that gets submitted centrally. And then you, as a peer, you can come to know that, look, I mean, everybody has that same metrics, or we have that same kind of errors happening everywhere. So these are certain quality indicators. You can convert them into sigma metrics and try to improve upon them. So ultimately what should happen is, the cycle has to go as, firstly, very importantly, you have to define what you want in pre-analytical or post-analytical. What are your problem areas? Please measure them properly, because if you don't define properly, the measurement will not be correct. After measuring, correct documentation, analyze them, improve upon where are certain centers are not doing well, certain technologist has an issue, certain instrument has a problems, the mails are not working correctly, there are IDs are not correct. So whatever is a pre-analytical or post, has an error, correct them, improve upon them, and month to month you can improve upon your processes. So ultimately it will result into overall matrix performance quality. About analytical quality, very simple, and we'll focus on analytical quality with association with total error. A very simple formula or sigma matrix on analytical is total error minus bias percentage upon CV. Now, what do you tell as a total error is very important. We'll get back to it at the later half of presentation. The bias and CV. Now, everybody knows about CV. So they can calculate through Excel if given this formula, you can easily do the sigma matrix for each of your quantifying assay. So biochemistry, immunology, hematology, all whatever is a quantitative can be estimated into, converted into matrix performance. Just an example, total error if I have taken from CLIA, it becomes 10%. My CV is 2.5. I've tried to calculate bias from indirect method. That EQUAS result is 130 and my peer is having 120 as my target. My bias becomes 8.33. My matrix performance is only 1.2. In spite my CV looks good, but my matrix performance is not so good. So bias is something where it is a difference between the true value and the observed value. A very ideal way to do the bias is the reference method, but indirectly you can get it from EQUAS. So EQUAS is proficiency testing, and there you can get whatever is the difference between your value and target value. There are certain EQUAS agencies which are having these standards, like HbA1c, creatinine has an IDMS traceable standard. These are known as commutable frozen serums are also available globally. So one can, if they want to measure bias at their end, these things are available. Simple formula of observed value minus target value upon the target value into 100 becomes a measurement of percentage bias. What is the problem area if you do bias from only EQUAS? Some EQUAS may have all method mean, which means every 3 part, 5 part, 7 part, even no part gets clubbed together. There is a method mean. So you may get a bias which is slightly higher. You may not have an absence of peer group. There are certain instruments which will do not have support systems where there are no groups which are available. You may not have the adequate numbers in your peer group. Now statistically valid is 9 data points for calculation of at least any method mean. Certain EQUAS would certainly, if we happen to know true value, those values, and if we directly enter into the software, I mean somebody enters into the peer groups, then the method mean will change. So the target may change even though you are not having a bias. Sigma works purely on define, measure, analysis, improve, and controlling. Sigma works ideally by this system. Actually, the green belts are a very basic training. Now KPMG holds the training for green belt Sigma. So they are part-timers and they help into that documentation aspect. Black belts, master black belts are full-timers, training, coaching, and strategizing. So this is very important for very, very large volume work where you are not, we all say that, look, I mean, pre-analytical needs to be controlled, but how and why and which is the right documentation. So that's how they would strategize, and they make sure that you concentrate on a right quality indicator. Modern days is about Sigma is clubbed with lean management. So that works with lean is related to the time actually, where it's very important that within time frame and turnaround times are so critical. So lean flow actually works on 8 principles, and Sigma and lean are actually applied as a whole. When you get 6 or more metrics performance in your, let's say, glucose or creatinine or basic testing of hemoglobin, where most of our analyzers these days, where if you take a high-end automation about Roche, Tri, or Johnson Johnson or Sysmex, Coulter, they would all produce analytical sigma at 6. But total error as allowed, the formula was allowed total error, and that is where now if we have an allowed total error, I've just tried to put it on to the slide where for an alkaline phosphatase, if you put it at 30, it becomes 8.6 matrix. If you reduce it to 28, it becomes 8. It reduce it to 22, it becomes 6. And CLIA actually has passed out 20 years of their existence. The CLIA rules are there, but then there are many other, many more quality specification requirements have come. And as a lab community, we should be knowing them. So what are they? We would get back to it. Sigma and lean should be, these are my references for sigma. My take-home messages I'll read out later, but total error estimation, both for qualitative and quantitative, more for quantitative. It's not a new concept. CLSI proposed in way back 2002 and finally drafted on 2003. Even industrial collaborations have started now putting not just CV but total error. And it is simple. Again, sigma matrix and total error are very easy. An Excel sheet can actually do the job. It's bias plus imprecision. You put 1.65 CV. So 1.65 in. So that's into CV of that particular analyte, and that is more than if the calculated total error is less than the allowed total error. It's a good performance. How you should select total error is the goal based on analytical performance has to be on clinical outcome oriented. So most of us are not aware about, like, there are clinical decision requirements and clinical decision points. That's called as decision interval percentage. At particular concentration, you are, for example, NCPE has classified at 200 milligram per deciliter of cholesterol. They want specification. So they want like, you want total error at that particular concentration at 10 or 12%. So that has to be kept in mind before you say what would be your allowed total error. Goal based on biological variations. Fraser has exhaustive list of biological variation. That's in between individual and within individual, day-to-day variation of each test. And goal based on all other things like what is your setup, what is your requirement, are we practicing. So these are certain six. I've just tried to put it all what is available on whatever are the quality requirements. So important ones are CLIA requirement, which we all understand and try to follow. But then there are biological error database, there are European goals, there are minimum analytical, optimal analytical quality requirement has come. RC path and German guidelines. So if, just to give you that example about glucose. Now at biological error database, they have put it for the plasma as 5.5 specification. Unlike CLIA, which is having 10%. So again, if you do total error, and allowed total error is only 5.5, then you need to do your bias and CV further tighten up. So that's how the whole game would initiate. And believe, because sigma and total error are calculations. The automation which is practiced by the Western world, we are following the same set of automation. So there should not be any, there's nothing gets changed except the calculation. So it's very easy, but you have to increase your product quality requirement. Something where these are all things where you can select any of them and be consistent with. These are cause of total errors and systematic and random errors. Why is it important for total error? Now, total error for a clinician can judge about medical error, just a borderline diabetic or a high cholesterol or a glycosylated at 6.5 is very important for them to know. Labs Yeah, because every day the manufacturer would come back to you with new and new, more and more instruments, new methodology. So how do you know whether that instrument is correct or not? So if we know, presently the manufacturer claims only about CV percentage or a precision criteria. So if it gets combined with total error, so we would know what is the reference method versus the total error. Again, direct estimation of total is always with the reference method, but indirect is with, as in sigma, it is biased with precision. In qualitative assays, what we can actually do is low positives and low negatives are run across the at cut points, and there are what is overlying overlappings gets into a total error estimation. Total error is useful for an evaluation of both qualitative and quantitative assays, but the indirect method is still preferred. The only thing is the direct method, there are CFS, the ideal reference methods are not so far, not easily available, and they are not cost effective. Sigma is here to stay. Actually, analytical performance is getting more and more importance. Application of sigma in pre-analytical process is very, very important. This is an area where even automation will come, but pre-analytical area needs sigma actually to come into the picture and start performing. They start measuring your performance in sigma, in terms of sigma, and focus on true documentation. Because unless there is a documentation, I don't think DPMOs can work. Because DPMOs works very stringently only if there are true documentation, and then only you can improve upon your processes. I'll be happy to take questions. Thank you.
Thank you, Dr. Trivedi. If any questions are there, we still have time. I had a question, doctor.
Yes.
When we look at bias, when we look at EQA programs to calculate our bias, and suppose we follow our bias month to month, and in first month I'm positive bias of 1%, next month I'm negative bias of 1%. So over the next 6 months, can I average out the balance bias and say that my bias is 0? Would that be the right thing to do?
So, sir is, yeah. So, there are revolving mean SD and there are revolving mean standard deviation index, which were there into the many EQUAS providers. What I look at is that the bias of current is so important for critical to patient care, because many things changes over a period of 6 months down the line or 3 months down the line. EQUAS is no good if it is done at 3 months. EQUAS is no good if there are, so I would still like month to month, whatever is the scenario, because a lot of things gets changed, and at that change, if my metrics performance is not less than 3, so I would be looking at that more.
So then what you would recommend is that after, as soon as you receive your EQUAS program, look at the bias, put it in the software, calculate my sigma matrix, and then decide which Westgard rule to use for the next month.
Yes, not, see, I mean, I won't be that, the Westgard rules are selected based on the precision. Westgard rules, very sorry. The Westgard rules are selected based on operational points and operational specification chart.
I would correct. I would say which would be a failure rule. I mean, if you are performing a 6 sigma, then 1 3S rule will be a failure. But then if you're looking at 5 sigma, 4 sigma, some other rules would also have to be considered.
So then my operating point at Opie Specs,
yes,
I would have if the line below, like, if you're performing at 6 or more metrics, so your percentage of imprecision will be less than 33%. So I would be rather too happy to use 1 3.5S for that particular analyte, And you should also see the last performance also before you change out your rules too frequently, because you should not bank on EQUAS these days, where, as I said, that EQUAS has many flaws within our country, where if you say that there are no neutral EQUAS, so EQUAS has to come out with the right target value also, because if it is not there, and it's not advisable to keep changing every month and come out with.
Thank you, sir.
Yeah.
Any other questions? Yes.
Yes. So Opie Specs is something where there are Westgard has put it as Opie Specs chart n equal to 2 with analytical quality assurance of 90%. It's easily downloadable. And n equal to 4. Again, how much direct metrics performance converted into which kind of rules to be used is also there. That's very current.
Yeah, I just have one comment. Like a lot of discussion about that risk-based QC is going on in the on the Westgard's website. What is this risk-based QC? Is it just Opie spec chart, or is it something else? Risk-based QC means that's the new clear standard that they have, I think, coming up with. Any update or any idea on that?
I'll update you.
Okay. Well, so second, just comment is that I find Royal College of Australia's quality standards very practicable to use. Reliback has a very difficult equation. We don't know. I personally couldn't know how to calculate that, whatever that Reliback equation is there in the German database. I personally couldn't do it. But Australian I found quite practical, means the lower limit at the lower side, what should be the accuracy, at the higher side, what should be the accuracy, means at higher level they have given percentages, at lower level they have given exact values.
Yeah,
At
right.
the medical decision points. That's the practical thing.
The RC path is perhaps the most comprehensive these days. Actually, CLIA has not evolved after what they have prescribed. The RC path has come out with at lower level, at higher level. They have changed with the automation also. So most of their data is based on Olympus 480. But they still have that lower level, higher level, and reasonably. Like, for example, 10% of glucose is now in RC path is 6%. So total error is just allowed at 6%. So, because most of us, if you are using at automation, are at 1.7 or 1.9 CV. So again, you are at 6 or above. So it makes sense to reduce your total error budget and try and do more precision.
And something about recourse goals. Recourse goals are, I practically find quite difficult to achieve, means recourse goals. Those are the biological variation goals, right? So what is your observation regarding recourse goals?
Little, because biological total error database is very difficult to convince the clinician. It would be, however, you can use within individual variation as your total error, and that if you can use that and produce your metrics, because end of the day we can only do a better analysis.
One thing is that, sir, if I want to buy a sugar, I won't need a sonar ka taraju. I need just 1 kilo. That's that much accuracy is not needed for some of the analytes, I guess. And sometimes recourse
It's
goals
not
are
about that. See, it's all about how your process. Like KPMG was telling about managements. So it's all about, these are tools. Don't put it on to isolation. No, let's not apply them only on hemoglobin or WBC count, which is anyway good. Anyway, you have seen the slides. Anyway, glucose में कोई फर्क नहीं पड़े. But overall, the labs works through processes. It's been said that it's the toughest business because it's a multi-step. There are many steps involved. A lot of people can go wrong. So you have to control all of them. To be able to do that, you have to have a good, consistent management. So to have that good management, there are many ways in which...
Quality goal should be based on the application rather than means the best
yes.
thing that we can do. Sometimes
Correct,
it might not be needed.
It's not.
Yeah.
Believe me, nobody follows everything. But
Thank you, sir. Thanks a lot.
Thank you so much, sir. I really appreciate you have come all the way from Ahmedabad at the last moment. Thank you so much, sir. So we break here. We have a small tea break, and we would be starting our next session at, I think, 5 o'clock. Thank you so much.